In this presentation, I will be discussing and analyzing Oregon's Death with Dignity Act. I will also be discussing how this policy affects the state of Oregon, as well as its impact on the people it applies to. Physician-assisted suicide is a termination of one's own life through the administration of a lethal substance by a physician, whether it be indirect or direct. Direct being when the physician injects a patient with a lethal dose of medication, or indirect where the physician prescribes a lethal medication for the patient to ingest. The recognition and definition of issue. Oregon's Death with Dignity Act attempts to improve the conditions or way of life that terminally ill patients experience post-diagnosis. Euthanasia is a century-old issue in the United States. Beginning in 1906, the first bill regarding physician-assisted suicide was drafted in Ohio. One of the earliest cases regarding the right to die was in 1915 when a woman named Anna Bollinger gave birth to a very ill infant and declined surgery for the baby after being told that saving the baby's life would be a waste by Dr. Hazelden. The issue around the ethics of euthanasia was found on the national level as countless bills have been proposed and drafted by states across the country. Many states, including California, Colorado, Vermont, and Hawaii, followed after Oregon in legalizing physician-assisted suicide for terminally ill patients. To the left, you'll see Dr. Hazelden with baby Bollinger, and to the right, you'll see a newspaper article regarding Dr. Hazelden's decision. The key actors in placing this issue on the legislators' agenda were the Oregon Right to Die Committee, created by a group of voters, Attorney Eli Stutzman, who drafted the bill, doctors, and patients diagnosed with terminal illnesses. Beginning in the 1980s, Oregon State Senator Frank Roberts suffered from prostate cancer. As a result, he introduced 3 bills concerning physician-assisted suicide for the terminally ill. While none of these bills were passed, they brought the issue to the full attention of Oregon's legislature as well as across the country. On the bottom, you'll see Oregon Senator Frank L. Roberts and Attorney Eli Stutzman. Policy formulation. There were many bills regarding physician-assisted suicide introduced by the states other than Oregon throughout the 20th century. Some states that proceeded in introducing this type of bill included Florida, Idaho, and several other states. Oregon's Death with Dignity Act found its roots in the Patient Self-Determination Act. This act requires hospitals that receive federal funds to inform patients of their right to refuse treatment. This policy followed both routine as well as analogous formulation. Oregon's current Death with Dignity Act was preceded by many similar proposals to Oregon's legislative system, which classifies it as routine. Oregon's Death with Dignity Act was finally passed after changes were made and paved the way for new policy formulations regarding physician-assisted suicide across the country. In the picture below, you'll see states that have currently legalized physician-assisted suicide, and those that are labeled in gray have not. Policy adoption. Oregon's Death with Dignity Act was enacted in 1997 after much debate and major drawbacks in the legislative process. There has been one change made since its enactment. In 1998, the Oregon Health Services Commission decided that physician-assisted suicide should be funded by the state for the purpose of preventing discrimination against the poor. This decision opened up many opportunities for those struggling financially to exercise their right to physician-assisted suicide when terminally ill. Below, you can see each state that enacted the Death with Dignity Act, as well as the method in which it was enacted. Policy budgeting. In Oregon, the Death with Dignity Act is an unfunded policy, so its outstanding annual budget is $0. While the state does not fund the legislation itself, there are costs for staff time. The estimated annual cost for staff time in relation to physician-assisted suicide is $18,850. Many organizations actually sponsor some terminally ill patients seeking physician-assisted suicide in order to spread awareness as well as advocate for this across the country. Below is an organization that funds and sponsors individuals seeking physician-assisted suicide. This is one of the most influential, titled Death with Dignity organization, and they are based in Portland, Oregon. Policy implementation. This policy was implemented using the capacity and auditory techniques. The capacity technique was used by proponents of the Death with Dignity Act when they decided to educate the public about physician-assisted suicide, as well as the struggles accompanying terminal illness. This was done through commercials, billboards, rallying, and other methods of public display. The auditory technique was used by the proponents of this act when they appealed to the sympathy and compassion among Oregon's residents. Cases such as Cruzan versus the director of the Missouri Department of Health was a booming topic in Oregon because it was used to inform people of the pain and hardship experienced by terminally ill patients. The Cruzan case was argued on December 6, 1989, and the decision was made on June 25, 1990. 25-year-old Nancy Cruz lost control of her car while driving near Carthage, Missouri. She was thrown from her vehicle, which resulted in a coma. After 3 weeks of being in a coma, doctors declared her to be in a persistent vegetative state. Cruzan's parents asked doctors to withhold life-sustaining treatment. After the hospital refused to listen to the request of the Cruzan family, the family filed for a lawsuit. This brought attention to many ideas of physician-assisted suicide and also how it may positively and negatively impact families. Policy evaluation. There is no official evaluation provided for Oregon's Death with Dignity Act. However, I was able to provide something similar to a policy evaluation created by a researcher of Charlotte Lozier Institute. The researcher discusses the use of psychiatric evaluation in order to ensure the mental stability of patients before taking on physician-assisted suicide. The most interesting thing I learned from this policy evaluation is that only 6.7% of patients were referred for psychiatric evaluation before proceeding with assisted dying from 1997 to 2011. The researcher discusses medical malpractice issues that result from the loose restrictions of the policy and how adjustments to the policy can be made to lower the rate of medical malpractice when handling physician-assisted suicide, such as official documentation of each step in the process and psychiatric evaluation in every case. The researcher also makes some interesting points as to how this policy can benefit as well as hinder families stricken by terminal illness. Below, I have included the requirements of psychiatric evaluation for each state that has enacted physician-assisted suicide. In Oregon, there are 2 oral and 1 written requests, and there are 15 days between a patient's second oral request and the prescription being administered. There also has to be 48 hours between a written request and a prescription. There must be 2 witnesses required. One witness must not be a relative or employee of a patient's healthcare facility. And if either physician suspects psychiatric or psychological disorder, the patient must be referred for counseling, and no prescription is provided without confirmation that the patient does not have impaired judgment. The diagnosis follows when 2 physicians agree that death is likely within 6 months. And the physicians also may refuse to participate. Below are my sources, and thank you for listening to my presentation.